admin.
I see. Okay. So the webinar is, well, it's 3 p.m. So,
Okay.
right.
No.
So do I see the audience? No, nobody. Nobody.
No, this is webinar setting, so no
Okay,
audience.
right. Okay. All right.
When do we start, Afiq?
We can start now. All right,
We can start
participant
now.
already in.
Yeah.
But perhaps
Give a few minutes because I see the participants are joining. The numbers are like 96, 97, 100. So give them a few minutes. 110.
can they hear us now, Afiq, or belum lagi?
Can,
Can. They can hear us.
because we have unmute.
Okay. Okay, I think we can start, Afiq?
Yeah.
Okay.
Yes,
Assalamualaikum and good afternoon, everyone. Welcome back to our GRIMS session. So we are very lucky today. We are very lucky because we have my old boss with us.
Bukan saja your old boss, everybody's boss lah.
Everybody's boss. Okay. And also we have Dr. Habibah, who is the HOD for Medical Hospital Selayar. Dr. Moliza, who is the medical head for Selangor, who will be chairing this session. Okay. Dr. Habibah.
Thanks, Dr. Azmila. First and foremost, thank you very much, Tan Sri, for having us to share your experience. And in fact, when we announced that you are going to have a session, the number of participants were actually quite a number. In fact, pediatrics is joining, A&E is joining. So in fact, if you see the numbers, it's just rising. It's now 165 participants. So I wouldn't take so much of your time, but allow me to share a brief CV of Tan Sri, even though his CV is actually very long. Okay, Tan Sri Datuk Ismail Marikan is currently the Pro-Chancellor and Chairman of the Board of Governors of Masa University, consultant hepatologist and internal medicine specialist at Prince Court Medical Centre, Malaysia, and Chairman of Gadang Holdings Berhad. He was the Director General of Health of Malaysia, President of the Malaysian Medical Council, Chairman of the National Committee for Clinical Research, Chairman of Drug Control Authority, Chairman of National Poisons Board, Chairman of Medicine Advertisement Board, as well as Chairman of Pharmacy Board from the 2005 to 2011. He received the Commonwealth Fellowship Award by the Commonwealth Scholarship Commission for Training in Hepatology Liver Diseases at the Royal Free Hospital in London in 1991 and set up the first specialized hepatology service in Malaysia. He has been an official examiner for the MRCP examination as well as the overseas advisor for the Royal College of Physicians of London for more than 3 decades. And he is also the best grandpa ever. So with this, I will pass the stage to Tan Sri.
Sorry. Thank you very much, Habibah, for those very kind words. And I must thank Azmila for her persistence and resilience in getting me to come forward. Thank you. And of course, Moliza, thank you very much to see you again. Now, today we are going to focus on MRCP PACES, particularly stations 2 and 4. Now, station 4, is history taking, and station 4 is communication skills and ethics. Now, a lot of people have found these 2 stations very challenging, especially Malaysians. And I have been examining for, as mentioned by Dr. Habibah, 3 decades. And invariably, I'm always involved in either communication or history taking. So I know the ins and outs and the behavior and the performance of our students, be it Malaysians or Singaporeans or wherever they come from. Now, the thing that comes to mind is this. Perhaps some people may perceive communication skills and history taking as the most difficult in the PACES exam because the rest are pretty straightforward. But history taking and communication skills need a little bit of tweaking and training and lots of practice. Now, some of you are first timers, and some of you are repeated, candidates. So I'm not sure whether you're first timers or repeated candidates, but whatever it is, you must remember that in the MRCP PACES, you must have a good grounding of the English language, like it or not. So you must make sure that you'll be able to converse and communicate effectively in fairly good English. Because if you don't have good English language to communicate, you shouldn't be sitting for the MRCP PACES exam. That is my view. So you got to be as smooth as possible so that both the examiners as well as the candidate or the surrogate or the patient understands what you're trying to say. Okay, now number 2, there are cultural differences between Malaysian candidates as well as those from overseas. Now, what do I mean by cultural differences? Cultural differences mean there are certain topics that are taboo to us. Like for instance, gay, hemophilia, drug taking, that's it. I mean, not hemophilia, I mean, what do you call, gay, and then you don't ask about IB drug use. We're shy to ask, so you don't ask. Because you're shy to ask, you don't ask. So to them, these MRCP examiners, it is an important omission. So you must try to ask these questions, but in a very subtle and sensitive way. Now, we don't want to blurt out and say, hey, are you gay? That is ridiculous. I mean, nobody will like that. You must know how to ask these sensitive questions. All right? Now, avoid verbal diarrhea. Some of them, they keep on talking and don't give a chance to the patient to speak. That is very, very difficult for the examiner to absorb. Remember, always look for non-verbal messages or non-verbal cues. You see, sometimes you say something and you can see the expression on the patient's face or the surrogate's face, and you know that you're not saying the right thing. So you must try and observe all these non-verbal cues very importantly. Okay, and then listen to the patient all the time. Be sympathetic and be empathetic, but please do not be artificial. This is my problem with some of our Malaysian candidates. They are so artificial, and I can see it a mile away, trying to be sympathetic, empathetic, when we know that they are not genuine. So you must make sure that you are not artificial and you do it naturally. And that needs a lot of practice, okay? And be non-judgmental. Just because you get, oh my God. No, cannot. You cannot be judgmental. And also avoid unjustifiable reassurances. What do I mean by that? You know the patient is going to die. You say, don't worry, we'll do our best for him. He will live longer, blah, blah, blah. So that is dishonesty. And that will give the examiner the impression that you're trying to be dishonest with the patient and the surrogate. So that's not on. So if you have to break bad news, you have to break bad news, but in a sensitive manner. Okay? Now remember, when you go to station 1 and 4, station 2 and 4, as with any other stations, make sure you introduce yourself and then find out whether the patient is the right patient. So confirm the patient's name and the age, very important. And of course, history taking, you all know, it's 20 minutes, so 15 minutes, 14 minutes for you to ask the questions, 1 minute for reflection, another 5 minutes for the examiners to have a go at you. Now, a lot of you tend to finish before 40 minutes. Don't say, I'm ready. No, you can't, because we will allow you to finish the 40 minutes. So if you have finished early, if you think you have no more questions to ask, then keep quiet until the 40 minutes are over. That's very, very important, both for the station 2 and the station 4. So that's very important. Now, you all know about the 7 skills that the MRCP PACES look for. And so I don't have to go through with you, but just to recapitulate. Skill A is physical examination. So that is not on in both history and communication. History B, B is of course identify physical sign. That of course is not on. But the rest of it is on. C, D, E, F, G, which is clinical communication. C, D, differential diagnosis for the history taking, clinical judgment, managing patient's concerns, and maintaining the patient's welfare. So in the history taking, we look at 5 skills, all right? C, D, E, F, G. And communication skills, we look at 4 skills. Of course, no differential diagnosis, just clinical communication, clinical judgment, managing patient's concern, and maintaining the patient's welfare. All right? Now, we have got about 1 hour. So let's just focus on history taking first. All right? That is station 2. Now, history taking is something that you should show the examiner that it is something that you have done all your life. Because we can tell. We examiners can tell whether you are trying very hard to take a proper history or not. So history taking is something that you do all the time. I do it even now when I see patients in Prince Court Medical Center. Now, your job in the history taking is to gather data from the patient, all right? Construct a differential diagnosis. Of course, you must give a probable diagnosis and then other possible diagnoses. Deal with the concerns the patient may have. This is sometimes a challenge. What are the patient's concerns and how you deal with them? It's very, very important. And then construct a management plan. Explain clearly to the patient and to treat the patient with dignity and respect. So avoid all these medical jargons, Your job is to explain to the patient what you plan to do, why you do it, what are the important investigations in a very sensitive manner. And don't think the patient is stupid, okay? Now, the station feature, of course, written instructions will be given to you in the letter that you all know all that. 5 minutes before the station and 40 minutes, blah, blah, blah. So that one you all know. So I won't go into all that because this is something that you already know. Just some salient points which I think are important in history taking and from my observation over the years. First of all, no physical examination, all right? And then please use full 14 minutes. Now, first thing I would ask is, what is your chief complaint? What brought you to the hospital? That is very important. And the history of the present illness. Now, I will always ask, in a difficult patient especially, when were you last well? There are some patients that give you all sorts of, I've got this, I got that, I got this headache, I got pain in eyes, I got macam-macam. So your job is to find out what brought the patient to the hospital and when was the patient last well. So that can give you an indication as to when the whole thing started. And then you want to know whether the process is sudden or whether it's gradual. Very important. And then quickly go through the systems review. You're going to be short and sharp, and please do not be stiff. What is your medical history? What is your social history? How is your... No. You cannot afford to be stiff. You can make it casual. That's why I said lots of practice to show the examiner that you've been doing this all your life. That is what I look for. If I see somebody is stuttering and all that, I know that this patient has just woke up from bed and probably doesn't know what he or she is doing. Now, past medical history to me is extremely important. And when you take a medical history in the past, you must also take past surgical history. All right, so medical and surgical history. And I would also like to add history of blood transfusions, especially for those who suspect to be hepatitis C, for instance. Nowadays, of course, you check blood for B and C, but those days, they don't. So it is important, especially in a patient who's got very severe fatigue, you want to find out whether he has had blood transfusion some 20 years ago. It's very important. So history of medical illness, past history of medical illness, past surgical history, and history of blood transfusions. Now, second thing is medication. Now, most of us ask about drugs the patient are taking. Now, some patients may know, may not know. Some patients say the color of the tablet, which is ridiculous to me as far as I'm concerned. Color doesn't give you any indication as to what the particular drug is. So the patient must be taught how to identify the drugs. At least know these drugs are for high blood pressure, these drugs for diabetes, these drugs for blah, blah, blah. They should know. If they don't know, then it is to their detriment. So I always educate my patients as to what drugs I give them so that they know. Now, importantly, a lot of us miss out on supplements and herbal remedies. Now, do you know that supplements or herbal remedies can lead to liver failure? We have had many cases in Selayang, for instance, when the patient had liver failure and nobody bothered to ask whether she was taking some Chinese herbs. So it is important when you take the medication history to also take the history of taking supplements and herbal remedies. Supplements are safe, more or less, but there are supplements that can cause derangement of liver function tests. So you need to know that. So you need to know everything about what the patient is taking, all right? Now, personal history is very important. What job? Now, marriage is sensitive. We always say, are you married? You know, perhaps the masalah, I mean, those people in the West, they don't like to assume that you are heterosexual. So you must say, are you staying with a family? You know, maybe you're married or something like that. You know, be very casual. So he may be married, he may be divorced. And if so, if he been married, how many years has he been married? How many children has he got? If no children, don't make your face scowl. Say, oh my God, no children. No, cannot. You must be natural about it. And this is a lots of practice, yeah. So marriage, job, how many children, how long has been married, and smoking and alcohol is very important also. Now, a lot of us, patients say, do you smoke? No. Okay, next question, alcohol. No. This is two areas where you cannot accept the first answer the patient gives you. If you ask for smoking history, then if the patient didn't know, then the next question is, have you ever smoked? Oh yes, I was smoking 20 cigarettes a day for the last 20 years, but I stopped in 2000. So that's important statement. Or alcohol. You don't have to know the amount of units and all that he's taking. Just how often does he drink? How much does he drink? And when does he drink? You just want to be assured that he's not a chronic alcoholic. Okay? You don't have to know the units. How many units you take? How the hell would he know? Okay? It's important to know whether he's taking beer, wine, whiskey, or spirits. That gives you some indication. All right? Now, the other thing that we seldom ask is IBDU. And sometimes when you see some marks on the cubital fossa and all that, you tend to, but I think it's important to just politely ask, say sorry to ask this question. I always do that even now. Have you ever taken drugs or intravenous drugs, blah, blah, blah. You have to ask these questions. But if you don't ask, the examiner from UK will say that you are not complete and you have committed an omission. So you must ask sensitively. That is a key word, sensitive. And social history is also very important. What does he do every day? Does he drive? That's an important question for a patient with epilepsy. Does he drive? Or has responsibility to send his grandchildren to school, whatever. So if he's got a stroke, he cannot do that. So that may affect him. So it's important to know whether he drives or whether he takes the bus. And the family history is also very important. This sometimes you may want to ask open-ended questions. You know, you don't want to be so specific. Any family, any history that you're concerned about, especially high blood pressure, diabetes, hyperlipidemia, cancers, liver diseases. These are part of a family history. Now, if they say no, my next question is, have they ever taken a test? For instance, hepatitis B. Mother got hepatitis B? No. Did she check for hepatitis B? No. No? So the question is zero. So you must ask. If they don't have a history of hepatitis B, is it because they went for a check or is it they assume that they don't have hepatitis B? So remember, there are certain questions that you need to expand and not accept at face value. All right? Now, allergies, very important. Any allergies to drugs, to food, A travel history, of course, these days nobody goes traveling, but it's important to us. Have you been outside Malaysia? And then last but not least is vaccination history. To me, I think that is, once you ask all that vaccination history, travel history and all that, then you know that you have been as complete as possible. And examiners will be very happy with you. Happy with you because you have asked it in a way that is sensitive and you are thorough and no omission. Okay, so that's history taking. Now, before you close, you allow patients to ask questions, and you may or may not want to summarize to the patient to see whether you have missed any points, but it's up to you. But the examiner will definitely ask for you to summarize, and then they will ask you, what is the most probable diagnosis and what other diagnosis do you have in mind? So the examiner will actually examine for 5 skills in history taking. That is D, C, F, E, and G. So D is, of course, a sensible differential diagnosis. So you must give probable diagnosis first. What do you think the most likely and why? And what are the differential diagnoses and why? All right. And then comes clinical communication to be done in a very systematic manner. Because the examiner will look for any omissions in the history, any unresolved ambiguities. That means patient has already told you that he's not sure about certain things, and you did not make any attempt to resolve those concerns of the patient and ambiguities. So that's very important. So these are things the examiners are watching for. So your interaction with the patient must never be artificial. It must be as if you care for the patient and you just want to help the patient. Basically, that's the story. Now, managing the patient's concern, sometimes you have to seek, detect, and acknowledge the concerns. And this is where you don't give them false or unjustified reassurances. Don't worry, you'll be okay. No problem. That is something which I will never forgive. If a patient has got cancer, don't worry lah, he'll be okay lah, he'll be okay, don't worry. Cannot. This is the problem with Malaysian patients, Malaysian candidates. They keep on saying nice things to think that they think that the examiner will be very happy with them for having this positive interaction with the patient. But no, you have to be honest, but be sensitive about your honesty. All right. Now, and don't give patient any false hope. Very important. Patient will be very angry. Okay, that's fine. But this is history taking we're talking about. Now, clinical judgment and appropriate. I mentioned the word appropriate management plan, including investigations and treatment. For instance, if you suspect pulmonary embolism, the appropriate management plan is what? You want to do a Doppler, you want to do CTPA, you want to do VQ scan, whatever. And you must tell the patient why you are doing that. What are your concerns and what are their concerns if they do not do those investigations that you have suggested. All right. Now, maintaining welfare of the patient, be respectful to ensure safety, comfort, and dignity of the patient. Never compromise on that, because this is key. The moment the examiner sees that you're making patient uncomfortable, or worse than it was before he or she sees you, then you're failed. All right. Now, both the examiners, they will be calibrating to decide what is satisfactory and what is unsatisfactory before you come in. So if certain points you do not mention, they will deem it as unsatisfactory. And certain points that you do not mention, may be satisfactory. Okay, never mind, we allow that. But certain points you must mention. If you don't mention it, they will put you as unsatisfactory. And unsatisfactory is bad news. Okay. Now, what are the possible scenarios in history taking? Now, I can think of fatty liver, not because I'm a hepatologist, but I think that is a new kid on the block. A lot of people come to see you with abnormal liver function tests, right liver on the ultrasound. You know, they're not comfortable, or the GGT is raised or something. So they will come and see you. So it's up to you to convince them that they need to see you. And then you have to explain to them the different types of fatty liver and what the serious types can lead to. All right, and why they need to do more investigations and improving or changing their lifestyle and that sort of thing. The second thing, of course, abnormal liver functions are very common, can be due to anything, can be supplements, can be drugs that they're taking, can be antibiotics that they're taking, even fatty liver, whatever. But they can come to see you with an abnormal liver function. Tell the GP, go and say the GP send the patient to you, right? The other one is GIT bleeding, hematemesis or melena. So you have to establish whether it's hematemesis or hemoptysis, for instance. Is it a local bleed or a systemic bleed? You want to know that. If local bleed, fine. If systemic bleed, different sorts of causes. And if it is hemoptysis, then you have to identify it's hemoptysis, so you focus on the respiratory system. If it's hematemesis, where the blood is not so fresh, not so bubbly, not so frothy, not so reddish, maybe it's blackish or maroon colored, then the focus, whether the patient could be have bleeding from varices or bleeding ulcers or whatever. All right, so that's important. Patient can come with abdominal discomfort, diarrhea, constipation. Now, that itself can trigger a lot of questions on diarrhea, on constipation, on abdominal pain, abdominal discomfort, abdominal flatulence. All right, headache and migraine are very popular. People come with headache. Okay, what are you trying to extract from the patient to arrive at the diagnosis of the headache? Because that itself can be a headache. To try to arrive at the diagnosis for headache can be a headache. All right, so you have to establish whether it's headache that is dangerous or headache that you can take your time to. Is headache associated with nausea, vomiting, or blurring of vision or vomiting? Then you're a bit concerned. You have to tell the patient it's urgent. Now, migraine, whether there's a certain pattern to it, whether it's just one of the migrainous attacks that he or she has been having, or it's something new. So you have to establish that. So headache and migraine is something that you need to know a little bit about. Don't send everybody for CT scan or MRI brain scan. So the examiner is very important. He's watching you, to see whether you are trigger happy. Trigger happy means everything, investigation. You think that it will solve the problem. No. Patients, they want to know what they're paying for. Is it important to do it? Subject them to all these investigations. So you have to convince them. And the only way to convince them is to tell them what are the dangerous or the signs that will lead you towards investigating further. Now, the other thing is faint, CVAs, and muscular weakness. And these are also very important history-taking questions, So patient with muscle weakness, patient with a stroke, and of course, strokes can also be in the clinical communication skill, but to arrive at the diagnosis of whether the patient had a stroke or Bell's palsy or upper motor neuron seventh nerve palsy is very important. So you have to be well versed with that. Dizziness and loss of consciousness, another favorite question. The patient says, I lost consciousness. So you have to establish whether it's fit or faint, whether any bite mark in the tongue, that sort of thing. So this is very important. Examiner wants to know whether you are thorough, whether you're thinking straight. Diabetes and thyroid problem is very, very common. Now, diabetes can be in many, many forms. There are patients who have diabetic complications, patients who've got diabetes for the first time, patient may have impaired glucose tolerance, patient may have subtle thyroid problem, maybe just a TSH that is prolonged, nothing else is wrong. It's the TSH is either high or too low. We've seen that. Patients otherwise normal. What do we do with them? So you need to tell the patient what to do and what not to do. The next thing on my list, I've got 10 things. No, I mentioned already 8 things. The 9th thing is lung, respiratory problems, COPD, cancer, bronchiectasis, pneumonias, pulmonary embolism. You must be very good at all this. And you must convince the patient that whatever you do or suggest is the right thing to do. And lastly, on my list, there can be many more, but on my list, chest pain, palpitations, breathlessness. The patient can come with any of these, and it's up to you to tell the patient whether it is something they need to be concerned about. Is the chest pain due to myocardial infarction, or is it chest pain due to pneumothorax, or is it chest pain due to reflux esophagitis? What is the breathlessness due to? Is it effort intolerance, or whether it's heart failure, whether it's a respiratory problem, whether it's asthma, blah, 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 all sorts of things. So in other words, you yourself must have the knowledge and the capacity to be able to decide what is important, what is not important for the sake of the patient. So now we move on to communication skills quickly because it's already 3:30. Now, communication skills is something we Malaysians, unfortunately, have problems with. History taking, okay, like just ask the right questions and you're okay. But communication skills and ethics, that is a big challenge. And I find it very uncomfortable sitting with the British examiner, seeing the performance of Malaysians in communication skills and ethics. All right. Now the idea of that particular station is to assess your ability to guide and organize the interview with the subject who may be a patient, a relative, or surrogate, as a healthcare worker. Explain the clinical information, apply clinical knowledge, including knowledge of ethics, to the management of a case or situation, and provide emotional support. But don't keep on saying, I understand, yes, I understand. That's what we Malaysians seem to be good at. Oh, I understand. But do you really understand? Don't keep on repeating stuff that can be quite irritating to the examiner, especially to me. And then you must provide emotional support, treat the patient with dignity and respect. And it's very important to convince the examiner that when you handle this sort of patient, they are looking actually for 4 skills, not 5 skills in history taking. C, E, F, and G. Now, the first thing is you have to be calm. In any clinical communication skills, you have to be calm. You yourself must not be thyrotoxic. All right? And you must expect the unexpected. The patient may start crying in front of you, or the surrogate may start crying in front of you, or the surrogate may start cursing you, angry with you. And you also, padan, I also can get angry. Cannot. You are being examined. So you must deal with the unexpected. So expect the unexpected. All right? And be always calm. And sometimes, as a gesture, if a patient cries in front of you, offer tissue lah. Can I give you a glass of water, please? Do you need somebody else to be here with you? Things like that. I mean, you really care for the particular surrogate or patient or whatever. So tissues, water is important. Getting them to get emotional support from somebody else. Now remember, the patient must have the capacity to communicate with you. In other words, the patient must understand what you're saying. If the patient do not understand what you're saying, you're wasting your time. And the examiner can tell, oh, this fellow is wasting our time. So you must make sure the patient understand what you're saying. Not only understand what you're saying, but retain the information. Make decisions. All right? So if the patient cannot do any of these, that means your communication skills are faulty. So you must try to establish this. Do you understand me? You want me to speak English? You want to speak Malay? Blah, blah, blah. Of course, for the benefit of the British examiner, you would prefer somebody to speak English. If not, you speak Malay, the examiner will not understand. So, but you must ask the patient, do you mind if I speak in English, or do you need an interpreter or something? You care. To show that you care. All right? So that is what you start off when you do your communication skills. Now, clinical communication, of course, in a systematic and thorough manner. Explain to patient disease, investigation, treatment, and don't forget the risks of doing or not doing those investigations. Every investigation, every treatment has got some risks. You must explain them to the patient. For instance, you take carbimazole in a patient with thyrotoxicosis, you must tell them that they may have possible side effects. They may, or they may not. But it's up to you to inform them. And always be sympathetic. You know, some of our politicians, for instance, I mean, you get somebody who opposes you, you get very angry. Cannot. You have to be sympathetic. And by the way, what you practice during the exam is something that you should be doing throughout your career as a doctor. If not, it's artificial. It's just for the exam. It's for show. Pointless. I see a lot of patients who pass the MRCP and they behave as Mr. Hyde. No more Dr. Jekyll. So what I'm trying to tell you is I've been in this business for so many years and I don't think I've lost any of the skills that I've been teaching you all. So it's important that you exhibit those things that I'm talking about now throughout your career. So that it's not artificial, it's natural. Now, managing patients' concerns, seek, detect, and acknowledge, listen sensitively. Sometimes we do not listen. We listen, but we are not hearing. There's a difference. Yeah, sure. You're writing down, listening. But you're not hearing. And you're not observing the non-verbal things. So must listen properly. Make sure that they understand what you're trying to say. All right? And how to minimize risk. There are certain things that are risky. How do you minimize them? Any other important information that you think may help? For instance, a patient with a heart attack, smoking, we have to stop, but you cannot pull a cane and say, stop smoking. You cannot. You must have a way of dealing with it. Ask the patient how you feel about smoking, that sort of thing. There must be, each patient has got different, idiosyncrasies. So you have to tailor your questions to make sure that each patient receives the best and appropriate treatment from you. And if the patient is anxious, there are many patients very anxious, you must deal with it in a sympathetic manner. Don't say that they're anxious and so it's a problem for you. I cannot handle you, you're too anxious, you're too this. Tak boleh. All right? Now, clinical judgment, I already mentioned, appropriate management plan, including investigations and treatment, knowledge of law and ethics. You don't have to be a lawyer, but you must respect the law and ethics. For instance, I got one patient the other day. He said, oh, I want to see you now. I don't want to see the other doctor. I think the doctor is terrible. Blah, blah, blah. I cannot say, yeah, you're right. That fellow is terrible. You must come and see me. Cannot. This is ethics. You cannot degrade another colleague. All right? And whatever the patient tells you is very, very confidential. But you don't put a spanner in the works and make sure that, you fan the flame. Don't do that. It's terrible. Always remember, respect of patient autonomy is very important. And ensure the patient is safe, comfortable, and has dignity. Now, the thing that you need to do in station 4 is summarize the plan of action before the closure. Ask the patient whether you've missed anything. Because the examiner is going to ask you all this summary. And candidate needs to identify the ethical and or legal issues and how to address them. And then it's always important to know, for instance, when you walk in, what does the patient know firsthand about the problem? What do you know about your problem? Does he know anything? So you don't assume that they don't know anything. You must assume that they know something and you want to know what they know. And this is where you don't use medical jargon at all. That's the worst thing that you can do. All right? Now, the important principles in communication skills and ethics are, to me, 5 things, basically. Respect for the patient's autonomy. All right? And duty to do good all the time. Always trying to do good. And duty to do no harm. To do good, to do no harm, respect patient autonomy, and some legal aspects. And the last one, which I think is also important, especially for cancer patients, when they go on internet, they read about this fantastic treatment that is available elsewhere and all that, but whether it is right for you, for the patient to ask you those drugs. For instance, the patient may say, hey, I've heard about this thing on, on internet and all that, what do you think? So you cannot poo-poo it and say, don't worry, like this internet is all nonsense. Don't listen to the internet, all nonsense. You cannot. So what you need to do is to tell them the pros and cons or whatever they're saying and whether it's good for them. And it may be controversial, but that is your point of view. You have weighed the two together, but you do not poo-poo it. Okay, don't poo-poo it. This is something that is called justice. So justice for patients' requests to be on a certain form of treatment, they read elsewhere. Maybe some friends tell them to do that. You cannot just dismiss it, okay? So you must be able to interact with the patient and tell them, yes, I've heard of that. Okay, that's okay, but it's still experimental. And then, so we cannot try that in Malaysia yet, blah, blah, blah. Any ways of telling a cat, okay? Now, you must know when and from where to seek further advice and local support. For instance, home nursing, hospice care. You must know. The cancer patients, they have lost everything actually. So there are certain treatments that may or may not be appropriate. So if it's not appropriate, so you send them for hospice care and improve the quality of life. You don't keep on giving them chemotherapy, you're giving them false hope. To me, it's false hope because you know it will not work. In a patient with stage 4, we have tried everything and they're still going on and on and on with all the side effects. The more advanced the diagnosis, the treatment, the more side effects they may get. So you don't want to impinge or encroach on their quality of life. So you got to explain to them all this. Unless they insist. And they insist, then you tell them. All right? And this is where the family comes in. But you must know the support groups. You have to. The local situation, you must know. Now, again, I have listed out possible scenarios in the communication skills and ethics. All right? So I would leave some time, for questions so that you all can ask me to what you have listened. Now, the first thing, of course, is the stroke patient. Now, the stroke patient has got a lot of questions to ask you. Is my hearing okay? Is it permanent? Is it temporary? Can I still drive? Can I work? Macam-macam. So again, you must be calm and be able to assist the patient to address their concerns. So stroke is a very common thing in the clinical communication skills. Number 2 is dementia. Now, dementia and Alzheimer's are two different things, okay? Dementia is very general and Alzheimer's specific brain problem. So there are 10 things or 7 things that you must know about dementia. I won't bother to tell you what it is, but you must be able to tell the patient or the surrogate that you may have dementia, but how do you tell it to the patient? All right. I mean, if you forget things, fine, everybody forgets things, but that doesn't mean you got dementia. There must be 7 things that are important and that disturb their lifestyle. They cannot get home. They don't think properly. They cannot write a proper check, blah, blah, blah. All sorts of things. So you must be able to identify dementia. They may ask you about Alzheimer's. So you have to tell them it's a type of dementia, but it is not alternative. It cannot be just dementia equating to Alzheimer's. Okay? Because dementia is very generalized. Now, the next one is a family with cancer. How do you deal with it? Now, some patients, they want the family to be involved. They want the friends to know what they are suffering from. Some patients, they're very secretive. They're very private. So you have to respect the autonomy of the patient. If they don't want anybody to know, fine. Okay, but if the patient is the patient with cancer, and he doesn't want the family to know, then you must know how to handle it. Okay, because obviously patient deteriorating and the family must know what is going on. Okay, so it depends on who you are dealing with. The fourth thing is weight loss. People are losing weight for no reason. Why? Is it deliberate? Is it cancer? Is it thyroiditis? Is it uncontrolled diabetes? What? You have to know. Okay, these are concerns that patient has. The fifth thing is medical errors. Now, sometimes we make some errors in the hospital and patient gets very angry and we get very defensive. Can't. You cannot do that. If you have made a mistake, you've got to be honest about it to the patient. You must take the bull by the horns. You cannot deny. So it has happened. You have to explain to the patient so that you deal with the situation. Errors do happen. It doesn't mean it's medical negligence, it's errors. All right. Wrong patient getting wrong medicine, for instance. Remember the former Minister of Health, some Lee, So that patient, he was telling us that they amputated the wrong leg. So you have to be very careful about all this. Okay. And diabetes is also again very important. Insulin, giving of insulin. Some people do not want to have insulin on their body. They don't like insulin. They think it's dangerous. They think it's injection. They think it's like those old days where the nurse come with the glass syringe and all that. And you got to tell them, to convince them that the time has come for them to be on insulin. Because we're talking about type 2. Type 1, they have to be. Okay, so type 2, whether they have to be on insulin or not, and you have to discuss with them. Of course, you can gain weight by giving insulin, by giving sulfonylureas and all that, but you have to explain to them. All right, and there are certain drugs that will cause weight loss, like metformin, for instance, like DPP4, SLG2, blah, blah, blah. So you have to inform them what is the best way forward. Okay, and don't forget the cost. Like liraglutide and all that, it's very costly, but do you really need it? Next is tremors. Tremors also can be a question in communication skills. People with tremor, what kind of tremor? Intention tremor, essential tremors, resting tremors, what tremors? All right, so you have to try to tell the patient that these tremors should be investigated. This one should not be investigated. All right, if it disturbs his lifestyle, of course, it has to be investigated. Or if it is progressive, it has to be investigated. If it is associated with other symptoms like bradykinesia and all that, it has to be investigated, right? The next one is rheumatoid arthritis. Now, a lot of patients come with rheumatoid arthritis and they cannot function anymore. So to them, it's distressing. So they want you to be able to guide them through and see how they can cope with the disease. All right? So when I say rheumatoid, it could be SLE and Sjogren's, whatever, but basically it's rheumatoid arthritis. And multiple sclerosis is, of course, something that is very common in the West, but maybe not here. But it can happen. The ninth thing is dealing with death, grief. So this is, again, you have to be genuinely sympathetic, empathetic, how to deal with this. My mother just died. So, oh, is that so? Oh, fantastic. I cannot. You have to be apologetic, not apologetic, sympathetic and empathetic. And the last one, number 10, is relationship. Your relationship with your partners. Your relationship with partners means spouses, And what is your relationship with doctors, with caregivers? To me, it's an important element because I've got a patient who said the wife is basically a problem. All the investigations are normal, but the wife is a problem. And she doesn't want to see anybody who she doesn't trust. So, without establishing a trust relationship, that patient will never get cured. You'll forever think that all the doctors are terrible fellows. They cannot solve my problem. So the first step I would do for this particular friend of mine is, okay, you make sure that she undergo all those tests, do a full neurological examination, and if indeed there is nothing to find, if it is a problem of the mind, I didn't say mental, I said problem of the mind, then she has to see somebody who she likes, who she trusts. And that is relationship. Okay, somebody who can bring her out of her misery and interact. That's very important. So ladies and gentlemen, I think I've said enough about history taking and communication skills and all that. It's almost 3:50 now. But let me conclude by saying a few things. This is conclusion before I answer all your questions. Again, I would like to reiterate, you have to be well versed in the English language. Speak clearly. Don't mumble. I hate it. Speak clearly with confidence, not overconfidence. Okay? With confidence, but not overconfident. You can smell it. You can see it. Examiner will hate it. So don't be overconfident. Be confident. Be clear. And be able to communicate with the patient well. Number 2, you must be prepared. You must plan well. Remember, failing to prepare is preparing to fail. So you must be prepared. And you must practice and practice and practice. Because it can tell, the examiner can tell whether you have been practicing or not. Okay? Of course, you got to be knowledgeable. If you don't have the knowledge, how are you going to advise the patient? What are the investigations? What are the treatment options? So you yourself have to be knowledgeable. Be broad. Don't have to be so detailed in any specific area, but be broadly based and be knowledgeable in most things. I already mentioned to you the scenarios. Maybe those scenarios are very important for you to know. And again, show genuine compassion, empathy, and be non-judgmental, and do not be artificial. This is the biggest worry of Malaysian candidates, artificial. I don't like it. And I'm going to tell you, if I say artificial, that's it. All right? Now listen more than talk. But don't listen all the time and never talk at all. So listen as if you are trying to understand the patient, not just listen for the sake of listening. Listen with a view to understand what is the patient's concerns. All right? And some questions have to be open-ended. Like, what are the chief complaints? Family history has to be open-ended. Cannot be too specific. So basically, you must put yourself in the patient's shoes and show that examiners that you are in charge, you are responsible, you're honest, you're natural, you're empathetic, and you respect the patient's rights and autonomy. If you can tell the examiner you have all these qualities, then MRCP is just like a walk in the park. Okay? So, now we've got about 7 minutes, I think, for questions. So if anybody wants to ask any questions, I'll be very happy to answer them.
Thank you very much, Tan Sri. I think there's one question in the Q&A column. So it's a question from Dr. Zen Fong Chia. His question is, good afternoon, Prof. I would like to ask, if we are taking the exam in Malaysia, which country law should we use, Malaysia or UK?
Malaysia.
For example.
Malaysian, of course. Malaysian.
Okay, because the example given was patient with fit. Should we ask them to inform DVLA or insurance? Patient want to complain, refer them to Pulse, etc. Thank you. That was the question.
So the question is this: you must follow Malaysian law. If the patient has a fit, then it's responsible for the patient not to drive. All right. Now, whether they inform or not inform is entirely up to them in the beginning. But if it is a recurring problem, then they have to inform. If it is just once, it just occurs once, the fit can be due to hypoglycemia or something. So you have to find out what is the cause of the fit. If it's a recurrent fit, if patient got epilepsy, of course, you shouldn't be driving unless they're very well controlled. So follow Malaysian laws. Next question.
Any other questions from the doctors sitting for exams? In fact, there's someone here asking, while waiting for other questions, Tan Sri, any suggestion or hints to remain cool and calm during the second station for communication?
Okay, this is a very important question. Unless you are thyrotoxic or you are yourself nervous person, now you have to try to be cool and calm. Before you go in, you have to be already exhibiting coolness and calmness. How can you do that? Practice. If you have already practiced and you have prepared for the exam, of course, you'll be cool and calm. But if you don't practice and you're not prepared for the exam, then it is very likely that you're nervous and it can show. The examiners will say that this guy is not prepared enough or hasn't done enough practice. All right. So be cool and calm. Of course, it depends on your personality. There's some people who are cool and calm in the crisis situations. There's some people who are not. That's one category. The other category, if you can be cool and calm in front of an examiner, if you have prepared for the exam and if you have practiced long enough. So that's my 2 cents worth. The rest is up to us, you know. But don't take any drugs just to keep yourself cool. Like students used to take beta blockers. You get so slow and then the doctor will wonder what happened to you.
Then. Okay, thanks, Sri. Dr. Azmila, anything to add on? So far, there were 2 questions there. Dr. Moliza? Okay, the second question is, greeting, Prof. For breaking bad news, if a patient with cancer would want to know the prognostic percentage of the specific cancer, may I know if we have to give the exact percentage of prognosis? Thank you.
Well, if the patient wants to know about the prognosis of a cancer, now the percentages depends on where you read, okay, which journal you read. So, but you have an inkling of how grave prognosis is. For instance, a patient with pancreatic cancer, you know, patient with pancreatic cancer, the prognosis is pretty bad. Patient with lymphoma, the prognosis is pretty good. Patient with liver cancer, depending on the stage. So it all depends, but you have to be honest and truthful because the patient was asking you and you have to tell the patient. Excuse me, dry throat. Nothing to do with COVID. So basically, if the patient has got cancer and the patient wants information from you, you have to tell them. All right? There's no hiding of facts. There's some cancers that are tolerable, maybe a few more years, but there are some cancers that are very fast. Like 3 or 4 of my friends with lung cancer stage 4, the most 18 months. You know, but you are not there. You're not God. You're not going to tell a patient you got only 15 months to live, 12 months to live. You're not going to say that. You're just talking about prognosis, likelihood, percentages, you know, from journals and articles that you have read. Okay, so you have to be truthful and tell them what you know. Don't give them false hope. That's what I'm trying to say, you know. To me, I think quality of life is very important, you know, for patients with cancer. All right, must be surrounded by the family and allow emotional support and, you know, hospice care. All right, there are some patients who are surrounded by friends who say, take this, take this, take this, take this, take this. I've seen a lot of those, you know, take this, take this, take this, which is all unnecessary. All right. Any other questions?
Okay, thanks, Tan Sri. I think so far there are no other questions, and almost 300 participants have participated today. And for those who are...
Yeah, I hope they understand what I've said so far. No question me either they've heard it before or whether they know all about it already.
They are still absorbing and digesting, Tan Sri.
Okay.
In fact, this session is recorded and we'll be sharing the link to all of them.
Right.
So,
okay.
But I must say, and I agree, everybody agrees, this is extremely important and very useful lecture. And we also benefited even though we're
Thank
not going
you.
to sit for exams. So, in fact, the first batch is going to start in the next few days, and
Yeah.
quite a number from Selayang as well sitting for the exams. So I
Yeah.
would like to thank Tan Sri for your time and for your sharing. I would like
Okay.
to thank Dato' Azmilah, who has actually initiated this talk, and she has persuaded Tan Sri, and Tan Sri has agreed. I would also like to thank Dr. Moliza, Dr. Lechman, Afiq, who has been every week kindly, creating the link to all of for the session. Okay, thank you everyone, and thank you very much, Tan Sri.
So for all those people who are sitting for the exams, whether you're first timers or second or third timers, all the best. And I hope this session has been useful. Remember, these are two stations that people find it difficult, especially Malaysians, you know. So even in UK also they find it difficult. So it's not difficult. All you need to do is to make sure that you cover all those points which I've mentioned and practice, practice, practice and plan ahead. Then you should be okay. All right?
Thanks, Tan Sri.
Okay.
That's a very, very
Thank
important
you.
advice to all.
Okay.
Thank you very
Azmilah?
much, Tan Sri.
Okay, bye-bye. Take
Thank
care.
you. Bye.
Bye.
All right.
Thank you.
Okay.
Bye.
Bye.